The two-dimensional echocardiographic examination is performed by directing a beam of ultrasound into the chest cavity. The echocardiographic transducer serves both to transmit the beam into the chest and to receive the ultrasonic signals that have reflected from structures within the chest. For the two-dimensional examination, the ultrasonic beam is swept through an arc, creating a fan of ultrasound corresponding to an 80-degree sector. Ultrasound will not penetrate the rib cage or sternum, nor can it be propagated through the air in the lungs. Therefore, the examiner must find small ultrasonic windows which avoid these barriers. The standard two-dimensional examination is performed by placing the transducer in the intercostal spaces to the left of the sternum, at the apex, in the subcostal position, angulating up into the thorax, and in the suprasternal notch, angulating down toward the great vessels. Individual cases may require additional transducer locations, including the right and left supraclavicular and the right parasternal positions. The latter are particularly useful for Doppler interrogation in aortic stenosis. We begin the standard two-dimensional examination with the transducer in the left parasternal position. The ultrasound beam is first oriented along the long axis of the left ventricle. The structures that we will study with the parasternal long axis view are labeled in the drawing. Drawings of the various cardiac sections will appear throughout the tape. You can refer to them for quick review of the anatomy. This is the standard parasternal long axis view of the left ventricle. A small portion of the right ventricle is seen at the top of the screen. This is the ventricular septum, and this is the inferior wall of the left ventricle. Note that only the basal and mid portions of the ventricle are displayed. The apex is not visualized on the standard parasternal long axis view. The posteromedial papillary muscle is here, and this is one of the chordae tendineae connecting the papillary muscle to the mitral apparatus. The anterior and posterior mitral leaflets are open. The aortic cusps are closed. This is the aortic root, which is anterior to the left atrial cavity. The descending thoracic aorta is seen in short axis behind the left atrium. The coronary sinus is also seen in short axis here in the atrioventricular groove. This is a systolic still frame. The mitral leaflets have moved to a closed position, and the aortic cusps are opened. Note that the septum and posterior wall have thickened, thereby reducing the size of the left ventricular cavity. We will now display the image in real time. Notice the normal contractility of the left ventricle and the opening and closing motions of the mitral and aortic valves. We will focus on the coronary sinus using the zoom feature of the instrument, which is ideal for inspecting smaller structures. Note once more the location of the coronary sinus, in the atrioventricular groove, anterior to the descending thoracic aorta, which is also seen in short axis. Maintaining the left parasternal position, the transducer is rotated clockwise to develop the long axis view of the descending thoracic aorta. From the original parasternal long axis orientation, the transducer is tilted infromedially to obtain the long axis view of the inflow portion of the right ventricle. These are the structures that we will be studying in this view. This is a systolic still frame. The posterior and anterior tricuspid leaflets separate the right atrium from the right ventricle. This is the inferior or diaphragmatic surface of the right ventricle, and this is liver parenchyma. This is the entrance of the coronary sinus into the right atrium. This is normal tricuspid valve motion. Maintaining the left parasternal position, the transducer is rotated such that the plane of ultrasound cuts through the heart along its short axis. By tilting the transducer tip down toward the apex or up toward the base, innumerable short axis sections are displayed. We will begin the short axis examination at the papillary muscle level. The positions of the papillary muscles may vary from individual to individual. As you can see in this drawing, the most common location for the anterolateral papillary muscle is the 3 o'clock position, and the 8 o'clock position is the most frequent for the posteromedial papillary muscle. This is the anterolateral papillary muscle, and this is the posteromedial. Note that for this subject, the posteromedial papillary muscle has 2 separate heads. The ventricular septum lies between the left and right ventricles. Note that the right ventricle is incompletely visualized. In addition to the septum, the left ventricular segments include the anterior, lateral, and inferior walls. In real time, note the uniform contraction of all left ventricular segments. We will now tilt the transducer to image the left ventricle in short axis at the level of the mitral valve. This is a diastolic still frame with the anterior and posterior mitral leaflets in the opened position. This is the lateral commissure, and this is the medial commissure. All 3 tricuspid leaflets are also seen: anterior, posterior, and septal. In real time, note the normal opening and closing motions of the mitral valve, and again, notice the uniform contraction of all left ventricular segments. Next, the transducer will be tilted to the base of the heart, to the level of the aortic valve. In this still frame, the left atrium is visualized behind the aortic valve. This is the left atrial appendage. The right ventricle, right atrium, tricuspid valve, and atrial septum are only partially visualized. The right ventricular outflow tract curves anteriorly around the aorta, and here is one of the pulmonary valve cusps. A short segment of the main pulmonary artery can be seen beyond the valve. In this diastolic frame, the closed aortic cusps form a Y within the aorta. The right coronary cusp is adjacent to the right ventricular outflow tract. The non-coronary cusp is adjacent to the right atrium, and the left coronary cusp is adjacent to the left atrium. In systole, the valve opens with a triangular appearance. This feature is crucial in differentiating this normal 3-cusped valve from a bicuspid valve. Pay attention to this feature in slow time. In real time, note the position of the aortic commissures at 2 o'clock, 6 o'clock, and 10 o'clock, and also note the motion of the pulmonary valve. In this short axis view of the aorta, we are using the zoom feature to study the ostium and proximal portion of the left main coronary artery, which originates from the left coronary sinus of Valsalva. In real time, the coronary artery is visible during only a portion of the cardiac cycle. The right coronary artery can also be identified echocardiographically, originating from the right coronary sinus of Valsalva. Here is the ostium of the right coronary artery and a short segment of the proximal right coronary artery, which is a small vessel in this particular subject. Tilting the transducer superiorly, we reach the level of the pulmonary artery bifurcation. The aortic root above valve level is seen in short axis. Beyond the pulmonary valve, the main pulmonary artery is visualized in its entirety, and here is the bifurcation into the right and left pulmonary arteries. By maintaining a short axis orientation and sliding the transducer toward the apex, a short axis view of the apex can often be obtained. The apex of the right and left ventricles are separated by the apical portion of the ventricular septum. The apico-anterior, apico-lateral, and apico-inferior left ventricular segments can also be identified. The right ventricular apex is heavily trabeculated. Note the uniform contractility of the apical segments. We have now completed the short axis examination of the heart from the left parasternal position. Review the short axis anatomy as the heart is scanned in real time from the aortic valve level to the level of the papillary muscles. Using a computer with a frame grabber, we will now display 4 different tomographic sections simultaneously: parasternal long axis and short axis at midventricular level, mitral valve level, and aortic valve level. We will continue the two-dimensional examination by moving the transducer to the cardiac apex. The ultrasound beam is oriented along the long axis of the ventricles such that a 4-chamber view is obtained. This is a systolic still frame. Currently, the most commonly used orientation for the apical 4-chamber view is with the apex up. When two-dimensional echocardiography was first introduced, the instrumentation only provided for this apex up format. Consequently, echocardiographers have become fully accustomed to viewing the heart in this manner. Many institutions display this view with the left ventricle and left atrium to the right of the screen, and the right atrium and right ventricle to the left of the screen. In real time, note the normal motion pattern of the tricuspid and mitral valves. Several institutions display the apical 4-chamber view with this orientation. left ventricle, and left atrium to the left of the screen, and right atrium and right ventricle to the right of the screen. At the Mayo Clinic, we use this particular orientation. Therefore, when apex up images are displayed throughout the remainder of this tape series, you will see them in this format. In this systolic still frame, the mitral and tricuspid valves are closed. The morphologic right ventricle can be identified by the location of its tricuspid valve. Note that the base of the septal tricuspid leaflet inserts slightly toward the apex, below the insertion point of the anterior mitral leaflet. Another easily identifiable marker for the right ventricle is the moderator band. In this frame, the descending aorta is also apparent behind the left atrium. The image has been expanded. In the apical four-chamber view, we are imaging the inferior septum at the basal and mid-ventricular levels. This portion of the septum is supplied by septal perforators from the dominant coronary artery on the inferior surface of the heart. This is the apical septum, which is supplied by the left anterior descending coronary artery. The lateral wall of the left ventricle is usually supplied by the circumflex coronary artery. In real time, note the uniform contractility of the left ventricle, and also note the normal opening and closing motions of the mitral and tricuspid valves. From the apical four-chamber view, the transducer can be tilted inferiorly to develop a long-axis view of the coronary sinus. The coronary sinus is located in the left atrioventricular groove. It empties here into the right atrium. The transducer is rotated clockwise from the four-chamber format to image the left ventricle along its long axis. In this diastolic frame, only a small portion of the right ventricle is seen. Note the aortic root and the aortic valve. The aorta is continuous here with the base of the anterior mitral leaflet. This is the posterior mitral leaflet, which is considerably shorter than the anterior leaflet. In the long axis orientation, we can inspect the anterior portion of the ventricular septum, supplied by septal perforators from the left anterior descending coronary artery. This is the inferolateral wall, which may be in either circumflex or right coronary artery territory. In this systolic frame, the left ventricular outflow tract can be identified, leading to the opened aortic valve. In real time, note the motions of the aortic and mitral valves and the uniform contractility of the left ventricle. The transducer has now been rotated even more clockwise, and the tip has been tilted slightly laterally. This is the apical two-chamber view. The left ventricle and left atrium are separated by the anterior and posterior mitral leaflets. This is the anterior free wall of the left ventricle, and this is the full length of the inferior wall. This is the posteromedial papillary muscle. In this normal subject, all segments of the anterior and inferior walls are thickening normally. Through the use of an inversion switch, newer instruments do allow us to orient the four-chamber view with the apex down. This orientation is particularly useful for examination of congenital lesions. However, we are increasingly using it in the examination of adults with acquired heart disease. In this still frame, the left ventricle and left atrium are to the right of the screen, and the right atrium and right ventricle are to the left of the screen. Throughout this tape series, we will often use this apex down format in addition to the previously described apex up orientation. Maintaining the apex down orientation, the transducer can be rotated to develop the apical long axis view. Here the aortic root and aortic valve are well seen. In real time, uniform ventricular contractility is again apparent. We will now display the apical four-chamber, apical long axis, and apical two-chamber views simultaneously. The transducer in the subcostal position can be tilted such that the ultrasonic beam passes upward into the thorax or into the abdomen. This provides unique information about cardiac structure and also allows imaging of the inferior vena cava, hepatic veins, and abdominal aorta. This is the subcostal four-chamber view. Liver parenchyma is interposed between the transducer and the cardiac image. The right atrium and right ventricle are to the upper right of the screen, and the left ventricle and left atrium are to the lower left. The cardiac apex is not typically seen from the subcostal position. Mitral and tricuspid motion are apparent. By tilting the transducer anteriorly, the aortic valve is identified. Its opening and closing motions can be studied from this position, which is particularly useful for cases in which technical difficulties prohibit an adequate peristernal examination. From the subcostal transducer position, we can inspect the entire atrial septum. This is the most reliable position for evaluating patients for atrial septal defects. In some patients, particularly in those with enlarged right-sided chambers, similar information about the atrial septum can be obtained using a right peristernal transducer position. In this subject, the transducer with subcostal four-chamber orientation has been angulated to image the atrial septum. This is the left atrium, and this is the right atrium. The right and left ventricles are not completely in view. This is the lower portion of the atrial septum, where ostium primum defect occurs. The septum is very thin in the region of the foramen ovale. This is the location for ostium secundum defect. By rotating the transducer clockwise and angulating anteriorly, the superior vena cava is imaged. Sinus venosus defect occurs in this portion of the atrial septum that is adjacent to the superior vena cava. This is the right pulmonary artery in short axis. Some institutions use this format for the subcostal four-chamber examination. The apex is to the right of the screen. This is the right ventricle, left atrium, and right atrium. Liver parenchyma is interposed between the transducer and the heart. As with the apical exam, we can electronically rotate the image from the subcostal position. The apex is now down and to the right of the screen, as though you were facing the patient. The right-sided chambers are to the lower left of the screen, while the left-sided chambers are to the upper right. By rotating the transducer and angulating the tip anteriorly, the superior vena cava is again brought into view. This is the right pulmonary artery. The atrial septum separates the left and right atria. In this particular view, we have increased the size of the field so that liver parenchyma below the diaphragm is evident. The transducer has now been rotated to the short axis orientation, and the tip of the transducer has been tilted toward the apex. The ventricles can be inspected at the papillary muscle level. This is analogous to the peristernal short axis view, but the image is rotated clockwise on the screen. This is the ventricular septum, separating the right and left ventricles. This is the inferior wall of the left ventricle, this is the lateral wall, and this is the anterior wall. The inferior wall of the left ventricle and the posteromedial papillary muscle are often partially obscured in this view. This means that this view is less reliable than the peristernal short axis view for the diagnosis of inferior infarctions. By keeping a short axis orientation and tilting the transducer medially, the left ventricle is imaged at the level of the mitral valve. In this still frame, the mitral leaflets are identified, anterior and posterior. This is the left ventricular outflow tract, anterior to the anterior mitral leaflet. The tricuspid valve leaflets are here, and this is the right ventricular outflow tract. We will now scan to the base of the heart. The aortic valve is immediately apparent in short axis. It is not usually as easy to identify the three aortic cusps from the subcostal position as it is from the peristernal. The left atrium is behind the aortic valve. Note the tricuspid valve leaflets and the right ventricular outflow tract, which leads to the pulmonary valve. Beyond the valve is the main pulmonary artery. The subcostal position allows imaging of the inferior vena cava and abdominal aorta. By tilting the transducer to the right from the midline, the long axis view of the inferior vena cava is obtained. This is a still frame of the inferior vena cava. This is the point where the cava enters the right atrium. This is a vestigial structure called the eustachian valve. In real time, note the characteristic venous pulsations. The inferior vena cava typically collapses with inspiration and expands with expiration. The transducer has now been rotated and tilted to inspect the hepatic veins. This is liver parenchyma. Two hepatic veins are seen, and they join the inferior vena cava here. Rotating the transducer back to the long axis orientation, the abdominal aorta can be identified by tilting the transducer to the patient's left. The spine is evident behind the aorta. This is the superior mesenteric artery. In real time, note the characteristic arterial pulsations. By tilting the transducer back to the midline and rotating 90 degrees, the ultrasound beam slices the inferior vena cava and the abdominal aorta in short axis. This is the inferior vena cava to the right of the spine, and this is the aorta on the patient's left. With proper tilt, the spinal canal is also imaged in short axis. In real time, note that the vena cava expands and collapses with respiration. With the transducer in the suprasternal notch, the ultrasound beam can be directed so as to inspect the aortic arch in long axis. In this still frame, we can identify a portion of the ascending aorta, the horizontal portion of the arch, and the proximal portion of the descending thoracic aorta. The origin of the left subclavian artery and the left carotid are also seen, while the origin of the brachiocephalic artery is not well visualized in this particular scan. Just beneath the arch is a short axis section of the right pulmonary artery. An attempt can be made to more completely visualize the aortic root and ascending aorta by angulating the transducer anteriorly and to the patient's right. In this subject, the entire ascending aorta is identified, all the way to the aortic valve level. A small portion of the left ventricle is also seen. Moving the transducer back to the midline position used to image the arch, clockwise rotation can be used to section the arch in short axis. In this still frame, the horizontal portion of the arch is in short axis, immediately above the right pulmonary artery, which is seen in long axis. The left atrium is below the right pulmonary artery, and in this view, the ostia of the pulmonary veins can often be identified. Right superior, left superior, left inferior, and right inferior. The superior vena cava is seen in long axis here, beside the arch. The superior vena cava can be investigated by moving the transducer to the right supraclavicular position. In this still frame, the aortic arch in short axis is not completely in focus. The left brachiocephalic vein crosses over the arch. The right brachiocephalic vein is formed here at the junction of the subclavian and jugular veins. The two brachiocephalic veins converge and form the superior vena cava, which is here seen in long axis to the point where it crosses the right pulmonary artery. In this subject, the superior vena cava is again being imaged from the right supraclavicular position. A small linear structure can be seen moving within the jugular vein. This is a venous valve. In this expanded view, focus on the motion of the jugular venous valve. We will now discuss M mode, which remains an integral part of the normal echocardiographic examination. This discussion will include a brief description of M mode structures. M mode data is obtained by directing a linear beam of ultrasound into the chest cavity. The beam is represented on the screen here as a linear series of dots, which we refer to as an M mode cursor. This cursor can be guided through regions of specific interest by using the two-dimensional cardiac image. This is usually accomplished with a left parasternal transducer position. When images are not available from the parasternal position, the subcostal position serves as an alternate. Here, we are utilizing a parasternal short-axis view of the left ventricle at the level of the papillary muscles. The M mode cursor has been directed through the ventricle, and this is the corresponding M mode display. The vertical axis represents the distance of various cardiac structures from the transducer. Time is represented along the horizontal axis. The M mode pattern thereby provides a means to precisely measure chamber dimensions, wall thicknesses, and valve excursions at any given point during the cardiac cycle. The motion of the ventricular septum is represented here, between the M mode display of the right ventricle and the left ventricle. This is the inferior wall of the left ventricle, and this dark line is the pericardium. As the M mode is generated in real time, note how it precisely depicts the changes in left ventricular dimension that occur throughout the cardiac cycle. This M mode tracing demonstrates various ventricular measurements that can be made using the calibration scale. These measurements include the right ventricular internal dimension, the left ventricular diastolic and systolic dimensions, the thickness of the septum and the inferior wall in diastole and systole, and the systolic excursion of the inferior wall and septum. The ultrasound beam has now been tilted to the level of the mitral chordae. The resultant M mode pattern is very similar to that of the valve leaflets, which we will discuss next. Here, the M mode cursor has been directed through the short-axis view of the left ventricle at the level of the mitral leaflets. The anterior mitral leaflet moves with a characteristic M-shaped pattern, while the shorter posterior leaflet moves in mirror image with a W pattern. Standard labels have been applied to the mitral M mode pattern. The point of maximal early opening excursion is labeled E. Following this, during the rapid filling phase of diastole, the valve moves toward a closed position along the E to F slope. This slope flattens with conditions that impede left ventricular filling. The E to F slope is followed by the period of diastasis, which varies in length depending on the heart rate. The A point is the result of atrial systole, following which the valve moves toward its closed position, labeled C. The anterior and posterior leaflets come together at the C point, and they move together on a slightly anterior slope through systole until they begin to separate again at the D point. The B point does not actually exist for normal patients. It can only be accurately placed when the A to C closure line is interrupted due to elevation of left ventricular and diastolic pressure. The M mode cursor has now been guided through the aorta at valve level and then through the left atrium. This is the right ventricular outflow tract, and these parallel lines are the walls of the aorta. This is the left atrium. Aortic valve motion can be identified within the walls of the aorta. With normal, thin aortic cusps, it is often difficult to record valve motion throughout systole. In this case, the aortic valve opens and closes normally, but the cusps are slightly thickened or sclerotic. This makes it much easier to identify their M-mode pattern throughout the cardiac cycle. Typically, only two cusps are identified. The anterior is the right coronary cusp, and the posterior is either the left or non-coronary cusp, depending on the exact angle of the M-mode cursor. Note that the cusps separate abruptly with the onset of systole, remain apart throughout systole, and close abruptly at the end of systole, thereby creating a characteristic square box appearance on the M-mode. The cusps remain opposed throughout diastole. Systolic time intervals can be determined from the M-mode examination of the aortic valve. The ejection time is measured from aortic opening to aortic closure. The pre-ejection period is measured from the onset of the QRS complex to the onset of aortic valve opening. In normal individuals, one usually records the motion pattern of only one of the tricuspid leaflets. In this subject, we have placed the cursor through the anterior tricuspid leaflet, using the right ventricular inflow view for guidance. The motion pattern is M-shaped, analogous to that of the anterior mitral leaflet. This two-dimensional image is a peristernal short-axis view at aortic valve level. The M-mode cursor has been directed across the pulmonary valve cusp. As with the tricuspid valve, in normal individuals, we are usually only able to record the motion of one pulmonary cusp by M-mode. Also, it is usually difficult to follow the motion throughout systole. In this case, we can identify the diastolic motion pattern. Following atrial systole, the pulmonary valve domes toward the open position, creating this so-called A-dip on the M-mode tracing. This individual has a mildly thickened pulmonary valve, which moves normally. The thickening makes it easier to follow and record the cusp throughout the cardiac cycle. Here note how the valve opens, remains open throughout systole, and closes abruptly at end systole. In this tape, we have discussed the normal two-dimensional examination from the standard transducer positions, and we have shown how M-mode information is generated from the 2D exam. Subsequent tapes will deal with normal variants, with pathologic conditions, and with the Doppler examination.